So I know almost everyone, but in case I don't, I'm Danny Fallon. I'm the chair of the Department of Mental Health, and we are very happy to welcome back some faces that we haven't seen in a while, and also to get to see some faces we don't see often enough, even though we're all here together on the same campus. So thank you guys for taking the time to join us today. I am extremely excited about our guest speaker, who I'll introduce in a moment, and also for the discussion that will follow. This is meant to be fairly informal, to give you a sense of having something to chew on and think about in terms of the state of mental health in public health, but in an informal setting where we can actually look at each other, have a conversation with each other, rather than a sort of one-directional kind of communication. So I hope you had the opportunity to grab a drink and feel that this is a little bit more like a cocktail chat. We will start by our guest speaking for a half hour, maybe a little bit more, and then I will invite 4 current faculty members to join him up here for a kind of directed conversation, to let them kind of give their view from their perspective of the work that they're doing, how it integrates with what Ron has talked about. And you are welcome also to chime into that conversation. So it won't be a very formal panel where each person has prepared something, but rather an off-the-cuff chat with each other. So to start us off, I am really, really pleased to have our faculty affiliate, our adjunct professor, Dr. Ron Manderscheid, come and speak with us today. Dr. Manderscheid is the executive director of the National Association for County Behavioral Health and Developmental Disabilities Directors. So hardly ever say that, usually NACBHDD.
You can say it, you win.
Yeah, right. And many of you know, if you've been following our weekly emails or our newsletters or other things, that we're quite proud of him. He's had 2 recent awards that I think are telling of the stature that he has in the field. The first, I and some of us had the pleasure of hearing him receive the Carl Taub Award at the American Public Health Association meeting this past fall. And that was for lifetime achievement in really in public mental health. And around the same time, this was your year of awards, you also received the Public Policy Leadership Award from the New York Academy of Psychoanalytic and Rehabilitation Services. Did I get that right? And I'm going to read you just a little bit of quote from that, because I think it really is telling. So I'm sorry for reading verbatim, but I just think it's really great. This is from getting that award. For over 40 years, Ron Manderscheid has been one of the nation's most prominent and powerful advocates, academics, researchers, and proponents of the recovery, rehabilitation, rights, and community integration of Americans with mental health conditions. Most recently, he has been a passionate advocate for national healthcare reform, whole health, and for the greatly enhanced roles for peer-run services in the ACA environment. So please join me in welcoming Dr. Manderscheid.
Thank you very much.
So I want to thank Dr. Fallon for inviting me. I'm very pleased to come and do this. I have done and still do a lot of travel internationally, and I can go anywhere in the world and see students from this program. And they all appreciate that they have been here and what the program did for them as they went back to their own countries. I have a project right now in South Africa, and I go there once a year. Some of your students are in South Africa, actually, so you can be very proud of what you're doing in the department here. I always begin with the stories. If you don't remember another thing I say, oh yeah, that guy was here. I can't quite remember his name or his organization, but I remember the story, and it's a true story. So last week we celebrated the 150th anniversary of Abraham Lincoln's death. And Abraham Lincoln was quite a guy. He not only did wonderful things in the Civil War and the Emancipation Proclamation and slavery, he also did other things. He was the person who brought the National Academy of Science to the United States. He also was the person who created the system of land-grant colleges, where virtually every state in the United States still has, 150 years later, a land-grant college. And the intent was to open it up so it would be like the People's University, where anybody could go to the university. So he has a lot of accolades, but when I mention his name, you immediately, and every one of you has the image in your head of this man in the black suit and the top hat and the beard. And I'm sure you also have the image of him as a very severe person. You don't have the image of him as a person who would tell jokes and so on. However, he actually had a very good sense of humor, and he always told a story when he went out, and this is a true story. So he went out and he met with a group of doctors in Washington, D.C. He said, "Doctors, I want to tell you a story about your work. The patient is in the hospital, very ill, in the bed. The doctor comes in, and the patient said to the doctor, am I going to die?" The doctor said, "Absolutely not, you're not going to die." And the patient said, "Well, doctor, how could you possibly know that?" The doctor said, "Well, for your kind of problem, we have statistics. And our statistics show that for every 10 people who have your illness, 9 die and 1 lives. And in my practice, the last 9 have died." So that's literally a true story from Abraham Lincoln here. Okay, I'm going to show you a few overheads, and what I'm going to do here is try to point out some of the resets that the Affordable Care Act is bringing here that relate to what you do every day here and what you teach. So several quick cases here. So the first case, 616,000 Americans die every year of a heart attack or stroke. 1/3 of those cases are people with primary behavioral health conditions. 1/3. So the relative risk, if you have mental illness, is 1.4 to 1. It's a very high ratio, actually. So we have to ask, why is that the case? 50 million Americans live in poverty. The rate of mental illness in the lowest social class is 8 times what it is in the highest social class. And that's not a new finding. People like Bill Eaton and I know that that finding comes from Hollingshead and Redlich in 1954. Redlich redid the study in 1985 and found exactly the same thing. Nothing had changed in the 30-year intervening period. And then thirdly, public mental health lose 25 years of life on average. We did that study 10 years ago. That number has not changed in 10 years. There's one state that's been studied since then, and the results are basically the same 10 years later. So if you break that down, there are pieces to that number. So if you tell me you were born in poverty, I'm going to subtract 5 years off your life. If you then tell me you didn't graduate from high school, I'm going to take another 4 years off your life. If you then tell me I have untreated depression or depression that's poorly treated, I'm going to take another 5 years. And then if you tell me you were in the public mental health system, I'm going to take 11. That's how we get to the 25 years. Now, in those 25 years, there are a whole series of factors that we want to get into. And the point of this overhead is we spend all of our healthcare dollars on disease treatment and next to nothing on prevention and promotion. I'm sure you all know this in spades. And the actual numbers are, of the 2.6 trillion, 2.5 trillion goes to disease, and 1/10 of a trillion goes to prevention and promotion. The way to remember that, in Medicare, half of the Medicare dollars, it's about $450 billion a year, half of the Medicare dollars, so $225 billion a year, is spent in the last 2 months a person is alive. Half of it. Now, we spend nothing 40 years early when the person is smoking, but then we spend huge amounts of money when the person is literally dying in the hospital with lung cancer. That's the model we're talking about here. And the model, if we continue on, shows this kind of growth, and I guess I personally believe we can never actually get to 4.6 trillion by 2020. I think we're having difficulty getting to 3.4 trillion. I think we're about 3.3 trillion right now. So we have to change the trajectory about what we're doing and about the money we're spending, which brings in the Affordable Care Act. You all know all these things here. So Berwick's vision, better population health, better quality health care, and reduced cost, is now known as the triple aim. So I want to use that as a framework for what I'm going to talk about a little bit. The 3 aims are interdependent. Work on one influences the others. They can be connected through several pathways, and I'm only going to describe one plausible pathway here. So I always think because I teach at Hopkins. The first among equal is better population health. So what's involved here? So there's a logic. Your life chances play a huge role in your health and illness. Your life chances play a huge role in your access to health care, and your life chances influence your life in the community. Therefore, obviously, your life chances are very, very important, and your life chances are determined by the social determinants of health in large measure. What do I mean by social determinants? Cultural, social, economic, health, and environmental conditions that influence one's life chances. Some examples here. You all know these variables: poverty, discrimination, traumatic events, poor quality education, on. Abundant access to fructose. Huge issue in American society. Almost all foods have huge amounts of fructose, so as a result, we have a huge population that is obese. Positive social determinants, social support and inclusion. One of the antidotes for stigma is social inclusion. Nurturing and support of family, good health education, positive role models, and on and on and on. Access to quality health care, disease prevention, and health promotion. The vast majority of adults with serious mental illness and youth with serious emotional disturbance have an overabundance of negative social determinants and a paucity of positive social determinants. So you come to the question, what do you do about that? And I'm not going to go into it today, but a topic for discussion maybe a little later and even beyond this seminar, as I've been thinking about that, I am not certain that work on the social determinants is the appropriate role of the healthcare system. That in order to really work on these things, we need to bring new partners in. So for example, if I'm addressing poverty and income differential, I don't think that's the role of public health. I think that's the role of public policy and the government to increase the minimum wage, a different type of logic here, so it's worthy of a conversation. Negative social determinants cause trauma. Trauma causes mental illness, and I guess we now believe that about 75% of mental illness is due to various forms of trauma. So, we're stating the case of the importance of social determinants here, and I want to show you some examples of this. So this compares data between the US and the UK for people 55 to 64 years old by income level, by type of disease, and you see prevalence on the left there. So in every single instance, the prevalence is higher in the US than it is in the UK for the same diseases in the same age range population. If you then array it by income, both for heart disease and diabetes, it falls perfectly the way we would expect. Those who are poorest have the highest prevalence, and it works down to those who are wealthiest. The only difference there is in cancer, where that pattern is not fully held. So there are several points here. There are factors at play here in terms of the social determinants, both in terms of income and probably in terms of factors in our culture and our physical environment. Another example here. Life expectancy at age 25 by education. See, as you walk up, less than 12. If you're a man, we expect you to live 47.9 years. If you're a woman, we expect you to live 53.4, and we walk up to more than 15 years of education, 54 and 58. Then we look at the differentials. For men, it's about 7 years, and for women, it's about 5 years. So I get the idea. I'd say on average, if you tell me you were born in poverty and you didn't get an education, it has a huge effect on what's going to happen to you, and I can predict this already at age 25. Another example of this, life expectancy at birth by SES for the US, and you see from left to right, low income to high income, and then you see 3 time periods, 80, 82, 89, 91, 98, 2000, and you see the complete classic pattern here. There is not a single inversion in the table. Go over here on the left, the poorest. In 1980, among the poorest, we expected that person to live about 73 years, and by 2000, that person had gained from 73 to about 74 and a half. If you go over here on the right, among the wealthiest, was about 75.75 to about 79.25. So the second corollary here is the poor are falling behind relative to the wealthiest. So the poorest here gained only a little over a year and 3/4. The wealthiest gained about 3 years here. So you begin to see the tremendous impact that these kind of variables have. And if you then know that a huge portion of our population comes from the poorest, it's just very obvious we're starting in a very, very difficult situation. So there's a lot of work going on right now, and I just want to mention in passing, creating a culture of health. I actually believe business is ahead of public health on this issue. So business has learned if we create the culture of health in our business, that puts money into the bottom line. By creating the culture of health, they work on issues such as obesity, smoking, stress, all these kinds of things for their employees and also for family members. There's actually a study that shows if I take a particular group of companies that do this, I match them with a set of companies, similar size, similar industry that do not. The companies that do this have a much better bottom line in terms of their stock. That data is already published here. So a huge part of what we have to get into here in behavioral health is what I'm calling here the culture of health. So final observation on this, behavioral health care leaders will need to adopt the practices and tools of public health to improve the social determinants of health and population health for the populations we are concerned with here. Okay, second level. So I'm differentiating here 3 different concepts: doing an intervention at some level, doing something at the community level, and changing policy. There are different levers here that you can invoke. So an intervention, operation of our healthcare system, including social media, community, conditions in which people are born, grow, live, work, and age, and policy, structural drivers at the global, national, and state and county levels. Then I'm going to go to this. This is very complex, and can you all see that there? I'm not going to go through this. This is your homework. So when you go home tonight, you look up Sir Michael Marmot. Look up Sir Michael Marmot. Sir Michael Marmot was the chair of the WHO Committee on Social Determinants. He also has done a lot of work in the UK on implementing the social determinants model in the British Health Service and in the City of London. And this is the logic he used. So you see the policy goals way up at the top here, and then you eventually see those policy goals implemented for different populations and actually implemented down in delivery system actions. But his model deserves more than the 2 sentences I just gave it here. Okay, improving the quality of health care. So the feature of this that I'm going to talk about is simply about upstream activities in the healthcare system. So 35 years ago, we published a paper, and we didn't really think much of it at the time, where we said, well, you know, we don't really believe that health and disease are 2 ends of the same continuum. We believe they're 2 different continua, and we literally set it up as you see it in this overhead here. If you then take, and the idea being, I can locate everybody in this room into one of the quadrants here. I hope most of you are in the upper left-hand quadrant, but it may be that that's not fully true, but I would hope that that's true. And what we're dealing with here is illness, the classic way you would define it, and health as a complete state of mental, physical, and social well-being, and not simply the absence of disease, which is where we got the idea originally. So if you take this concept and you apply it in behavioral health care, you would get a model like this. So if you're down the lower right and you move horizontally, you're doing traditional biopsychosocial interventions. If you move vertically, you're into some of the new things. You're into wellness interventions, self-help, social support, changes in unhealthy lifestyle, some of the things that we were just talking about. And the ideal here, obviously, is to move in both dimensions and move toward the upper left-hand quadrant. Now, I want to go ahead a little bit, introduce a couple more ideas. So there's great interest right now in health literacy and health activation. use an example to make that case. So if I'm a person who has depression, if I become health literate about my own disease, I will come to understand the triggers for my own illness. And for me, the trigger may be not sleeping enough, or it may be not exercising, or it may be some combination, but I will come to understand that. And once I understand that, health activation then is acting on that understanding to reduce the episodes of illness. And actually was a mentor to a brilliant guy this past year who was a senior person in Microsoft, actually, till he was about 40 years old. He got bipolar disorder. He left Microsoft, and now all he does is peer support work. So he's a classic example, but he's brilliant. So he intuitively understood the concept of health literacy and health activation, and he applies it to his own life. He watches this every day of his life, and he's able to avoid, or we believe he's able to avoid, episodes of depression in his life by being health activated. Part of my point here in this overhead is this is not only a person level concept, it is a community level concept. So I can look at health literacy about the community. So what is the health literacy we need to understand about East Baltimore? Huge issue for you all who teach it, or me too, I guess. And community activation. So if we understand these health literacy issues about what goes on in East Baltimore, how are we activating this in actions in the community to change those things? So actually wrote a number of commentaries on this, so if you're interested, we can pursue that. So now I want to go back to my illness health model and talk a little bit about prevention and promotion. So most of the work people do in behavioral health at the present time is in the lower right-hand quadrant. What we're going to have to prepare for is moving into the upper left-hand quadrant, where people who are going to come for care are not going to come for disease care. They're not even really going to come for disease prevention. They are going to come for positive mental health promotion. And the question becomes, how are we going to do this? And you have two intermediate classes here, the yellow and the red, different groups of people. So the person moving on the yellow is very interested in disease prevention. So how do I move from a state of more severe disease to less disease? You move vertically here. How do I move to a more healthy outlook, better physical, social, and emotional health, basically? So I think a huge agenda that we don't talk about at all in behavioral health is how we are going to move across these various cells, incorporate these additional groups into the people that we do serve here. And the Affordable Care Act, through the essential health benefit, actually provides a benefit for disease prevention and positive health promotion. So everybody who has insurance through the health insurance marketplace or through the Medicaid expansion actually will have that benefit. Our job is to make sure there's something behind having the benefit that actually works. So what is the evidence-based practice on positive mental health promotion? And I'm not sure I could answer that, and we could talk more about that. Go back to the three levels here, and these are just some examples. So prevention of substance use, the intervention, put in place drug-free community programs, community level, no pill mills. Go to southeastern Ohio, they have huge numbers of pill mills. If I go in and say, my God, I have a pain, they'll give me a bottle of pills like that, basically. The policy level, policies that support healthy lives free of inappropriate drug use. And I do know, and just found out, I guess it was yesterday, the Secretary of HHS, Secretary Burwell, is going to do a 50-state meeting on opioid problems, including Maryland. So you all may want to be involved in that or get on the group from Maryland that is participating in that. I expect that'll be held later in the spring. She has taken on opioid issues as one of the major initiatives for 2015. Another example, reducing trauma, removing ACEs from families and communities. ACEs are adverse childhood events. Community level, schools that do not permit seclusion and restraint. Policy level, policy to promote nurturing families and to provide sanctions for physical sexual abuse. So you see an example here. Here's the ACEs pyramid. Same logic I talked about before of people dying early. If you go through those various levels, you will die early. ACEs will cause you to die early, actually. Early intervention, another issue here. Facilitate early intervention through the use of social media and phone apps. Why can't we use phone apps for some of these things? Community level, change our culture so it's okay to seek mental and substance use care. So huge effort ever since Newtown has been to normalize seeking mental health and substance use care. And President Obama talks about this, the Secretary talks about this, Pam Hyde talks about this. It's about normalizing and using the communication channels that people use. So target audience here, people who are basically 15 to 25 years old. They don't communicate the way I'm talking with you right now. They do text messaging. So if you want to talk with them, you've got to be in their language, basically. The policy level, remove regulatory barriers to client-provider interaction via social media. We have many, many rules and laws that prevent us from doing things that need to be done here. Recovery support, another example. Intervention, social inclusion, community level, effective job and housing supports and opportunity structures, and the policy level, development of national behavioral health policy that promotes recovery and community inclusion. So these are all examples where you would take Marmot's model and apply it at these three levels in different problem areas. So the management observation 2, behavioral health care leaders will need to adopt new collaborative leadership strategies to implement integrated health systems that take a whole health person-centered approach, including the use of modern technology. A little simple sentence, hugely difficult to implement. And then finally, I'm almost done here. Third among equals, reduce the cost of care. So what's brand new in this area is 2 months ago, the Secretary announced what she calls the Value Purchasing Initiative. And the Value Purchasing Initiative is an effort to move all of Medicare money and all of Medicaid money into performance-adjusted annual case rates. Performance-adjusted annual case rates. So most of the money that's spent right now is encounter-based. So the more encounters I provide, the more money my system generates. So I provide more and more encounters to generate more money, and I assume that's going on right across the street here as we speak. The purpose of value-based purchasing is to say, we don't want to reward you for turning the crank more and more. We want to reward you for improving the quality of what you're doing. Hence, we're going to tie the case rates to performance measures. So there's a huge learning curve here that's needed by behavioral health care, and actually have done a little work on this with some groups and talked to them about case rates and so on. I think behavioral health people have a very weak understanding of these things, and I think they don't have the data systems to actually be able to create the piece of the pie that would be the behavioral health piece of an integrated case rate currently. So we had the opportunity to meet with the Secretary about 6 weeks ago, and one of the things we asked for was technical assistance at all levels, for state people, for county people, for providers, for academics. What do you mean by value purchasing? Show us some real live examples. We need technical assistance on building case rates. What performance measures should we be using, and so on. So if I were to guess, of all these things I've talked about, I think this one will be the most difficult of achievement, probably not even because of case rates, but because we don't agree at all on performance measures. So if we went around the room and asked you separately to write down a performance measure, and we put all the paper together, we would have 50 different performance measures here. That's the nature of that. It's a huge problem for us. So we need to move this agenda as well. So finally, my third management observation, behavioral health care leaders will be able to achieve cost reductions by managing payments to promote aims 1 and 2 more effectively. Clearly, the triple aim points to a whole new way of leading for behavioral health care, Your challenge will be to plot key strategies that will help all of us become successful in this endeavor, including part of what you're teaching the next generation of master's students and doctoral students here. So with that, I'm going to stop. This is my contact information. Let me tell you one little short story as the end. So if you don't remember the first one, you'll remember this one. So this is another true story. So when I was a freshman in college, I took a course in public speaking, and it met every Friday morning at 8 o'clock, always met for an hour. There were 23 people in the course. The very first day, the prof said, well, you know, every one of you is going to give a talk here every single Friday. And you're going to talk for 1 minute, and when the 1 minute's up, I'm going to hold up a piece of paper and you stop wherever you are. And of course, people said, well, you know, how could you possibly make any point in 1 minute or less? He said, not important at all. The critical thing is to be invited back, basically. So, true story, basically. Never overstay your welcome here. Okay, so we're ready to stop here.
Thank you very much. And so while that is up, Dr. Manderscheid didn't mention it, so I will. He also writes a blog. Many of the things that he mentioned very briefly in this short sort of snippet, he has entire articles about on his blog. And so if you look up, just even Google his name, you'll find that. And I think you'll find that really interesting. There's a listserv you could be on that will give you an email every time one of these new ones comes out. And it's really fun to follow and to hear perspectives on, including the mobile health stuff that you mentioned, and yeah, lots of. The other things I wanted to mention before we invite our faculty up to have a discussion is I was remiss in saying that Dr. Manderscheid indeed teaches with us, and he teaches 2 Summer Institute courses. So if you or if some of your colleagues are interested in those and really, you know, like to think about these perspectives, he teaches one that's on identifying, discussing, and debating unresolved national mental health policy issues, and another that is specific for knowledge for managing county and local mental health, substance use, and developmental disability authorities. So very practice-oriented course, and it's this June. I think we actually have dates for this year. 23rd and 24th for the first one I mentioned, and 25th and 26th for the second one I mentioned. And then last but not least, this lovely book that I just got a copy of, Outcomes Measurement in the Human Services. So that also is relevant to some of the things that you just heard. Might be quite interesting. And then just to give a span of some of the different areas of our faculty, we asked 4 folks who volunteered to or agreed to come and chat with us. So in no particular order, Dr. Joe Gallo, who's a professor at our department, is one of the folks who's going to come up. So Joe, feel free to come have a seat. Judy Bass, who is an associate professor in our department. Tamar Mendelson, who's also an associate professor in our department. And who am I leaving out? Ramin, where are you? He's not even. Yeah, right. And Dr. Ramin Moshabai, who is a professor in our department. Maybe we'll start by that. If there are folks in the audience who first want to just have a comment or a question of Dr. Manderscheid, and then after that we'll start with you guys. That gives you a little bit of time to gather your thoughts if there are things that you wanted to say in reflection or as a question. Anybody in the audience who wants to? Yeah, hand.
So I just had a question about the kind of like the quadrants that you had shown between illness and health. And I guess what I didn't necessarily understand is if health encompasses physical health as well, how people could be in the quadrant where it's healthy and
good question.
severely ill. Yeah.
So the actual WHO definition comes from the preamble to the Constitution of WHO. It says health is a complete state of physical, mental, and social well-being, and not simply the absence of disease. So it's modifying well-being. So I'm talking about physical well-being, mental well-being, and social well-being, not illness per se. And it's my perception of these things.
So we all know cases of people who had very severe cancer, but they address this in part and they reduce their own symptoms through their mental outlook. So that's the difference between what you're perceiving and the illness that you have, basically. And to talk a little bit about well-being, there actually are sets of well-being measures that were developed by the Centers for Disease Control that are part of Healthy People 2020. There are objectives in Healthy People 2020 about people's well-being, and what I'll do is I'll send over a little summary that actually goes into those 3 dimensions and then talks about some of the research that supports those 3 dimensions.
So I want to complain, maybe this is a little right wing, but about positive mental health. So positive mental health, should we spend money on positive mental health? So, and if positive mental health is the absence of illness, then it's the same thing. We don't have to worry about that. It's something else. If it's something else, what is it? So Corey Keyes says it's flourishing. So you can have a cancer patient or a person with schizophrenia who is actually flourishing. I don't disagree with that. But people often confuse the promotion of positive mental health with the prevention of illness. And I think the promotion of positive mental health is actually an individual thing. Spending money preventing illness is a very good thing to do. If you can do that by making people be cheery, that's great. But making people be cheery doesn't prevent depressive episodes or schizophrenia, I think. If it does, then you would spend money on it. So there's a conceptual mushiness which extends back into the World Health Organization definition, which I'm grumbling about.
Okay, so very good point. So I think the point you're really making is there needs to be a lot more work, which I guess is partly my point as well. There needs to be a lot more work deconstructing these concepts and working on them so that you can see how they fit together in a logical way in a theoretical model. So it seems to me the predecessor variables to what you're talking about here would be things like social determinants, like the culture in which and the social structures in which you live. Then determine your outlook, which then has an impact on your proclivity to get disease, basically. Now, you may not be able to prevent depression, but you may be able to make it less severe. And I think we've learned in spades that if you intervene in psychosis early, you can reduce the severity of the psychosis. So I would say that positive mental health is implicated in reducing the severity of psychosis over time here. But it's poorly understood. So I am agreeing with you. There's a whole lifetime of work here of working on this issue and breaking it down. And I think the way a public health person would talk about this, we have to stop just looking at people who have severe disease, and we have to put these people into the whole population and understand what it is about the population that generates so many people with disease.
So that's great. I just think we don't know that promotion of mental health prevents mental illness. When we do, that would be a great thing to do. And I do this in the course of psychiatric epidemiology. I have a section. I used to have a section. Maybe I will this year. I don't know. The students ask for it, positive mental health, and so I said, this is epidemiology. So you got to have a disease in the numerator and the population in the denominator. And positive mental health, what's the numerator for positive mental health? And for purposes of explanation, I came up with, you all, maybe some of you don't know this, Sharon Williams. And I told her she was the numerator for the epidemiology of positive mental health. Anyway.
Okay. Good.
So why don't we move on to you folks and your thoughts? And anybody want to volunteer to be first? I mean, yeah.
So thank you again for a very good talk. I'm coming from the perspective of a mental health services researcher, so I have to preface my comments. And I have to say there are very few people, I think, in this room who disagree with your aims 1 and 2. But it is really hard for me to reconcile your aim 3 with the first 2 aims, and I tell you why. When I look at the course of outcomes and functioning and quality of life of mentally ill people over the past 5 and 6 decades, I think one of the major advances has been Medicaid, for example, and SSI. And these came with a lot of funding and cost out of the government's pockets. So it's hard for me to reconcile that there's cost saving with improvement in quality. Cost always, in my mind, mean quality costs, and you can't really do one without the other. I don't know, you want to say
So
something?
let me comment then on that briefly. So I don't think saying reduce cost here means spending less money. I think it means spending your money better. And I would say, having been in the field 40 years, there's a huge amount of services out there that are poor quality services. We could be doing this much better. And I think the argument being made here in goal 3 is that we do that much better. I don't disagree with what you're saying. It's just the spin you put on the answer here. Yeah.
Yeah, and I agree, especially when I look at the ACOs and their focus is in cutting the cost of hospitalizations for Medicare population. But I don't think that there is as much excess fat in mental health care services. I think it is mostly in end-of-life services, in hospitalization for older adults. And so if we move that way, if we try to improve care by implementing those quality measures, that's another issue. First of all, what are those quality measures that we can rely upon? And you mentioned that it's very hard to come.
I laugh because I'm going to be on a panel next Tuesday to
Right.
talk about outcome measures.
Right.
And it's the outcome measures. So in HHS, there probably are at least 2,500 or 3,000 outcome measures.
And
Voice the back and forth a little.
2,500 to 3,000 outcome measures in HHS. So CMS, Medicare has outcome measures, Medicaid has outcome measures, SAMHSA has outcome measures, CDC has outcome measures. What are we going to do? So we have a Tower of Babel here, and a lot of our outcome measures tied to vested interest.
Right.
So I operate a hospital, therefore I want things that focus on a hospital, or I operate a community mental health center, or I'm a psychiatrist, or whatever. So I think we have to figure out how to get beyond the Tower of Babel, and the way I guess I will describe that on Tuesday, we need to push the reset button on our outcome measures. And I think we need to do this in a much more coordinated way. There is nobody in charge of this in HHS, nobody. And it's actually gotten more complex, and I used to work on this 10 years ago. It's gotten more complex and difficult in the last 10 years because there's many more measures now. And we're just spewing them out of these entities. So I think we have to stop doing that. We have to push the reset button, and then we have to ask some of the things I was saying before, how do we move this system toward the WHO definition? I'm coming back to Bill Eaton again. How do I improve physical, mental, and social well-being? How do I move from deficit-based measures to strength-based measures? How do I move to system-free measures? These kinds of things. It's a huge, huge undertaking. And I don't believe AIM 3 will ever be achieved until we resolve the issue of measures here. And you all have a huge role to play in that. You're experts in doing this. You need to help the field. The field is pretty incompetent regarding this type of stuff. It really is. And it needs the expertise of people in universities working on these things to help move the agenda. We don't want to end up, with 3,000 or 4,000 measures here, none of which anybody uses. It's ridiculous, basically.
Well, so the other issue, this would be my last comment, is that with some of these measures, and we know from a lot of health services, that providers focus on those measures. So, for example, screening for depression is a case in point. So if you make that a quality measure, all of the providers are going to screen for depression in all of their patients, and they're going to prescribe a lot of antidepressants. That's a major cost in mental health care, and they won't do anything else.
Yeah,
so that's the problem. With all
absolutely.
quality measures.
I agree with what you're saying. That is not a good. When you pick out a couple things that way, you cause all the energy. It's like teaching to the test.
Right.
It moves all the energy to that issue, basically, and you ignore other things. So we have to figure that out as well. You probably can't have one or two measures, so everybody says, you know, I want to move this agenda, therefore, in the Affordable Care Act, we have to get SBIRT into the Affordable Care Act, which we did. Well, now everybody does SBIRT, but you're right, other things are probably being ignored. So that is not the right solution here, in my opinion.
SBIRT.
Screening, brief intervention, referral to treatment for doing alcohol, drugs, basically.
I guess also thinking about aim 3 is the issue of getting coverage for prevention and health promotion within healthcare systems. So that may be linked to measures, but it's a bit different because right now the system is not set up to cover, insurance doesn't cover a lot of these things. And I know, in my research and thinking about implementing, screening for pregnant women with a tiered system of response that would include prevention and promotion of, I do believe prevention and promotion are linked in terms of promoting some resiliency that can make you feel good, but can also, well, we'll talk later, but I mean, I think
Okay.
I struggle
Okay.
a lot with, are these things sustainable in the real world if they're not going to be covered by insurance?
Good comment. So what I said before, and there are some things that could be added. So if you received insurance through one of the state health insurance marketplaces, or you received insurance in one of the 29 states doing the Medicaid expansion, you have a prevention and promotion benefit in your insurance. Now, it may not be the perfect benefit, but it's in there. So I'm going to say that maybe something around 17 million people have now received that coverage. So there's about 11 million in the marketplace and about 5 to 6 million in the Medicaid expansion. We need to get that into other policies. So in parity is a broader concept. Parity applies to everybody I just talked about, those 17 million people, plus everybody who receives insurance through an individual or small group marketplace now, plus everybody who's covered by a Medicaid program that's operated by a managed care entity, plus everybody in the CHIP program. So if you put all of those together, we are well north of 80 million people with parity. So if you have prevention benefits for physical health conditions, you have prevention benefits for behavioral health conditions under the condition of parity here. So we actually are reaching maybe 80 to 85 million people. Now, your point is still well taken. Parity doesn't go far enough. We should be having parity for everybody. If you have Medicare, you don't really have parity. It doesn't apply to Medicare. And it doesn't apply to Medicaid unless the Medicaid program is operated by a private sector entity. So we have big gaps in parity yet. So your point is, well, we need to work on that so that when you sit here 5 years from now, you can say, prevention has become pretty universal in most insurance, which it isn't currently. So I'm agreeing with you, but there's a strategy for moving the agenda, I think, here.
Sure. Yeah, fascinating discussion. One of the things that's quite striking to me, and many of us, I think, if you think about it, is that all of the systems for human services are failing. Whether you're talking about schooling, primary care, 60 million people uninsured, I mean, they're crazy levels of failure. The justice system, all over the place. So in some sense, what we're discussing has to be put in the context of these systems, if you call them that. And somehow or other, we need to reinvent a system that pulls these measures into one place so we have a shared view of what we're all about, even though we may do different things. So what I'm suggesting is that we see the conversation we're talking about in the context of a system of systems.
Absolutely.
So we're talking about putting primary care, public health into one, so they're not in fact separate, so that the primary care office doesn't keep on being a grocery store with treating people who walk through the door, rather than understanding the denominator of the community it sits in. We need an information system, but we don't need yet another one. We have 14 for kids over time. They don't talk to each other, so we have no transmission of information. So if you put public education, which has an information system, together with primary care and public health into a system of systems, and then think of the other agency services as somehow integrating kind of around a common structure, common purpose, that's life course embedded. A lot of the conversation we're having, it seems to me, would be much more relevant. How does a school teacher think of health? Well, it's attention problems. They get then sent, the kid gets sent at great cost and enormous time and lack of efficiency to a physician. So attention deficit disorder is the primary care solution to bad behaving kids who teacher doesn't have any training to create classrooms that know how to manage them. So what I'm suggesting is that this would be an important perspective in which to see these conversations, to think about the system.
Agree completely. Agree completely. And it needs work too. And I think part of the work is how do you link these systems? So I go back to adults with serious mental illness. If you simply get mental health care or you simply get primary care and you don't do these other things, and I live out under a bridge somewhere, forget it, basically. Because I need housing, I need social supports, I need job supports. Those systems need to be integrated together. And there actually is thinking going on a little bit about that. This looking at the social determinants over the life cycle takes that point of view that you have different things that influence your life over your life cycle, and we need to pay attention to those things or those systems as we go through life so that you have, in effect, a long and healthy life, and not just a life or a long life, basically. So there's a lot of work that's needed in this, and you know, there's some Brenner, Jeffrey Brenner in New Jersey, you know, has taken the 400 most difficult people and community that he's working in and say, I have to put together the system so these people can have a life, are healthy, and don't cost $5 or $6 million a piece a year, basically. And he's working on that. Other people are beginning to do I think the kind of work that you're talking about. I don't think that work is yet systematic at the national level the way I think you're hoping it will be, basically. So I'm agreeing with you.
So why don't we, just to keep going, go to Judy for the sort of global perspective of that last. So why don't, Joe, you give a couple of comments.
Oh, yeah, do it passive.
Yeah.
Hi. I want to say that I never took Bill Eaton's course, so I like to preface my comments with that statement. Huh? Right. And sort of my background's is actually in primary care and in family medicine, although you know it's behind me a little bit now. And just in terms of reacting, thinking through, in terms of your looking at your slides, one thing that comes up to me is a couple of things. So one is who owns health? In other words, how do we blend the models that incorporate the clinic with the community, that we're not going to solve many of these things we're talking about just with a focus on the clinic. So kind of what you're saying. The second thing is the workforce. So who do we want to train to do mental health? Who has to do that? And a couple of things come to mind. One is I'm working with a very nice psychiatrist here who is training community members to deliver an intervention to isolated older adults. And that accomplishes a number of things because older people in general, it's not that they receive lousy mental health care, they don't get any mental health care. Or if they get anything, you know, it's gonna be whatever comes from the primary care doctor. Another kind of comment is, you know, for 20 or more years, basically, I've been hearing like can you say the word crappy in this kind of, you know, what a crappy job primary care doctors do. But it's tough. And you're absolutely right about the depression, you know, the screening. But how do we integrate, that setting with the community and link that in a way that not only makes sense to us, but makes sense to the people who are suffering and who are not lining up to get depression care or whatever it is. I think that's very important. And one more comment that kind of underlies, I think, a lot of this, particularly for older people, is medical comorbidity. How do you take, treating diabetes and depression in a way that's integrated, that will make sense to people and they will want to deal with coping? These are often very hidden things. People aren't taking care of their diabetes, aren't taking care of the condition, and that smoking, and that absolutely has a huge effect on mortality and other things. So,
Agree.
First of all, as an alum of this department, it is so exciting to be able to have these events, because I don't remember having them, Bill, when you were chair. Or at least if they were to happen, or if they did happen, the students were invited. So first of all, I think it's exciting both as an alum to be part of this, but also to see these conversations, because I think one of the things that these types of conversations bring is the currency, the current what's going on, where the thinking about what's going on now, as opposed to reading the manuscripts that have, obviously the research has already happened and the manuscripts publishing the research. So first of all, thank you for coming, and I think that's really relevant. So the work I do is in the global context, primarily in low and middle income countries. So the conversations about systems means something completely different. Because in most of the places where we work, there are no systems, or those systems are so corrupt and so dysfunctional that those symptoms aren't useful tools for improving health and well-being. And one of the things that I found very interesting is your the two axes, the well-being axis and the disease axis. And in some ways, I think that's very helpful, because it frames things in something that's very helpful domestically. But in some ways, I think it's very unhelpful in the global context, because it's something that we see all the time. It's the NGOs, the non-governmental organizations, that say, we do psychosocial well-being. We don't do health. We don't do mental health. We do psychosocial well-being. We're not going to talk about mental health care, because that's not our capacity. We're interested in that well-being side. And so it continues the dichotomy. Whereas oftentimes when we talk with non-governmental organizations, we talk about more in a continuum, that people have both mental health needs as well as psychosocial well-being needs, and that organizations have more or less capacity to deliver different parts of those needs. But rather than being, one group does this and one group does that, which ends up being that there's an overabundance of unproven services for psychosocial well-being and an absolute lack of services for mental health needs. And I think one of the things that we're trying to bridge is that gap by saying you can improve well-being by improving mental health. And so one of the outcomes, talking about outcomes, one of the outcomes we use, and it's a very simplistic idea because we have to work in simple models in the global context, is not just happiness. Bill's question about are we trying to get people happy, is functionality. And functionality in terms of really tasks of daily living that are relevant to the context and the people we're working with. Do our mental health programs not only improve their mental health, but improve their functioning as individuals, as members of a family, as members of a community? And can other interventions also work together? So thinking of the cooperative between livelihoods and mental health and social programs all combined.
So I think that's a very good point. What you remind me of is work that the Carter Center has done in Liberia, and I assume you're familiar with that program, where there in effect was no behavioral health system. There was nothing. And they said, well, what would we do if we were to go and create something where there's nothing? So what they decided to do is train a cohort of nurses, and the nurses then are assigned geographically into different areas of the country, and the nurses do both nursing services and they do, in your terminology, psychosocial services. So I think there are models that can be put together to begin to address the dichotomy that you're talking about. And I guess if you compare it to developed countries, what we do here is not typical of what the world does. And so we are not necessarily the model for the world or how we would solve these problems here. And so, you know, how we go about solving our own things here may not be per se what you can immediately take to one of these other countries here. And I think, you know, the Carter Center is to be commended for taking on some of these things. And they not only, you know, have a staff in Atlanta that work on these things, they have to literally hire people from the local culture who understand how the local culture works and how the local medical establishment works and so on. So it's an absolutely huge undertaking, basically.
So I want to just follow up on that last thing, and then we'll get our second round of drinks with her. So I've sort of thought about this from listening to you and then knowing what Judy and some of the global mental health folks said, and I think I've mentioned this to both of you in different ways. In some sense, it feels like we as a domestic system have a lot to learn from what the folks in the global mental health system already kind of know. I mean, they've had to start from square one. I mean, they didn't have to hit a reset button. There was no button already pushed, you know. And so they're sort of boots on the ground figuring out implementation, like some of the things you just mentioned, getting the right, you know, stakeholders involved from the beginning, what's really needed versus what top-down is told is needed, figuring out how to sustain those things in a financial and otherwise way. Peer-to-peer things, which I know you're very interested in as a model here, is a necessity, you know, is sort of a necessary model already in those kinds of settings. And so I wonder how we get those fields to listen to each other a little bit more. Really, how do we get our domestic, federal and local governments to listen to what has been learned in these low and middle income settings? We have this sort of bias that we do it right and they need to catch up with us, but it seems to me that this is a place where we could really learn a lot more than we do.
And that's one of the things that we're continually talking about. What can we take from lessons learned? And I think one of the benefits of working in the low and middle income context is we don't have issues of licensure. We don't have issues of reimbursement. And so we have some benefits of being able to say, we'll train lay workers in evidence-based services, and they can implement it without having to have legal structures behind it, which is a benefit to us working in, you know, so we trained community health workers in Eastern Congo to provide cognitive processing therapy, which would require them to have pretty significant certification to be able to do that here, but there we don't have those legal structures. And so I think some of the stuff that our collaborators, our adjunct faculty, our associate faculty, and people are doing here around how do we utilize peers and paraprofessionals in implementing evidence-based components of programs where they can find that line of where it's appropriate for whom to provide what services. It's something that we don't actually have to deal with as much in the low and middle country context.
Yeah, I feel so. Most of my work is domestic, but I've done a little bit of work with Judy and her team, and I was really struck by two of the things you just mentioned. One of them, this task shifting or task sharing model. I had never heard that term domestically ever, but it seems like in parallel, that's something that people are talking a lot about in the States, and how can we broaden that conversation to learn from what is being done? Because there is a great push to use peers and lay workers here as well in different settings. And then the other piece too is, I think, taking components of evidence-based models. So we may not be able to do the full-blown, really complex treatment, but are there kernels that seem to work, that seem to be common elements across different kinds of psychosocial approaches, and can we deliver those in a more condensed version that's evidence-based? That's something that's also almost happening in parallel, but we don't always talk to each other.
Lee, last word.
The model is terrific, Ron, and I think you'll agree that outreach to the community is key, and to reinforce some of the recent comments about the importance of lay people being sort of the instruments to make that happen. We need a nexus between us and the community, or between clinicians across the street and the community. In my own work in disaster mental health, I've found the faith community to be vital linkages between what needs to be done and the people who will really be responsible for it. But even that, making that contact isn't all that has to be done. In some ways, there has to be education of the leadership, in this case of faith communities, because within several blocks of this building, there are currently pastors saying, you came to me with depression and you want medication, you want a psychiatrist, but what you really need is to get right with God and not go to a psychiatrist. So there has to be some education with that leadership.
Hear, hear.
Agree, totally.
Well, thanks to all of you for Dr. Manderscheid for coming, and for the four of you for volunteering to give your perspectives publicly. Appreciate it. So on camera. Yes, on camera at that. Before we break up and then just continue to mingle and get some snacks and things like that, I wanted to take an opportunity to just briefly acknowledge those of you who are alum who have come today. So if you wouldn't mind just giving your name and what program you graduated from within the department. So those of you who are currently faculty or students don't have to do this, but I particularly want to acknowledge those of you who are coming here, especially as an alum, to the event. So where shall we start? Want to start over here? Anybody? Yeah? Folks, yep, there you go.
I'm Cassie. I graduated 2013 from the Master of Health Science.
Great.
Where are they now? That would be great.
Sorry, Cassie, where are you now?
I'm a sort of next door at the emergency department. I'm coordinating the upscale of HIV testing program.
Great. We have a student doing ED work in autism crisis. So different world, but ED focused. So it might be fun to talk to him at some point. Yeah.
I'm Andrew Rock. I was in her class of 2013 MHS, and I'm currently at Virginia Commonwealth University. And you might know, but Dr. Mizek, I'm doing research with her down there.
Great. Go ahead.
Brandon Johnson. I was in the 2012 class. I was right before them in the MHS program, and I'm currently the state coordinator of suicide and violence prevention for DHMH.
Okay, nice. Yeah.
I'm Diana Paxarian. I was also 2013 PhD student, and now I'm a postdoc at NIMH.
Sure. Elizabeth Seaman. MHS 2013 is very well represented. But I'm currently a PhD student at the University of Maryland.
I'm Hannah. I was in the MHS 2014, so I graduated last summer, and I'm actually in the same program with Elizabeth at University of Maryland getting my PhD.
All right. Well, thank you guys for coming back, and thanks for. Oh, Linda.
I'm Linda. I'm MHS from 2014, and I've stayed in Baltimore. I've incorporated. I'm doing some online work, looking for a doctoral program, and it was just published 2 days ago in JAGS with vocal music and improved cognition in dementia patients. A long study on dementia.
Wonderful.
Yes.
I'm Robert Hall. Bill and Shep led me through quite a few years ago. And we just published our book on supporting and educating traumatized students that came out with Oxford. And we just got the contract for retraining all the teachers in DYS in the state of Ohio on trauma-informed care.
That's great. So as you already claimed, we have great alumni doing important things.
Absolutely.
Yeah.
Absolutely, all over the world.
Right. So thank you again for coming, and thanks to External Affairs for helping us to organize this.